Happy PA Week to all my incredible PA colleagues. I hope you feel appreciated and loved this week. And if you work with a PA, give them a high five or shoot them a text of appreciation. Let them know that we see you, we thank you, and we're celebrating you today. So welcome back to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. I'm Colleen Sloan, a PA, dietitian, and today I'm sitting down with Dr. Leslie Golden, a dual board-certified physician in obesity medicine and family medicine. She's also the founder and CEO of Weight in Gold Wellness. She brings both clinical expertise and lived experience to her work, helping patients heal their relationship with food and their bodies while addressing the complex drivers of weight. She's also writing a book called Snacks Make Me Angry, and you can bet we will definitely have to have her back on to talk about that one. So in this episode, we're tackling 3 very different patient cases, and you'll hear how an obesity specialist approaches each one, from a woman navigating menopause and those metabolic shifts to a man considering bariatric surgery. And finally, a young adult on a GLP-1 worried about side effects and questions about how long treatment will last for. Dr. Golden breaks down how she thinks through each one of these scenarios and unpacks how she would communicate to each patient's unique case and tailor their treatment plan. And I promise you, you are going to love this episode. But if it especially resonates with you, please take a second and leave me a quick review or share it with one of your colleagues who you think would benefit from this conversation as well. All right, well, drive safe, get comfy, and enjoy my conversation with Dr. Golden. Well, Dr. Golden, thank you so much for coming on to the podcast. Welcome to the show.
Thank you. I am so excited to be here. I can always talk about weight health and nutrition.
Well, our mutual friend connected us, actually, Nina Crowley, and she's been a guest on the podcast before, and she's been involved with a few projects with me, just like you were. So thank you so much for just sharing your wisdom in so many different areas. So I'm really, really excited to dive into a few of these different cases with you today. But before we even get into kind of picking your brain and how you would address different patient situations, can you just give us a quick refresher exactly on how obesity is classified and why BMI doesn't always tell us the full story?
Absolutely. I think this is such an important question, and we have to talk about it more and more. So we're so used to obesity being about our size, the space we take up, related to the scale, where it's this height weight calculation. And really, BMI was meant to just be a screen. And also to evaluate risk, really more for insurance purposes. And it was never meant to be a goal. It was never meant to be a target, because at the individual person level, it just really doesn't tell us a whole lot. So, there's these classifications of obesity that if your BMI is over 30, you have obesity. If your BMI is 25 or 27, depending on which criteria you look at, plus weight-related conditions, they'll say you have obesity. But obesity truly, as a clinical disease and as a medical disease, is about having more adipose tissue. So that's our science word for fat tissue. And in adipose tissue, fat tissue is an organ. And so having more of that than is what's healthy for our individual body. And also, it's not about how much we have, it's about how it relates to the other tissues, the quality and the health of that tissue, and also where it's distributed on our body. So it's really much more complicated than just, what do you weigh? How is it related to your height? So if you don't have something like bioelectrical impedance or DEXA to confirm adipose tissue of a certain amount in the body and the health of it, then we try to use additional measurements like waist circumference and do like a waist to height ratio, waist to hip ratio. But if someone is only using a scale, like a traditional scale, and using your height and weight, they're not getting an accurate picture of your health. And you cannot diagnose obesity that way.
Yeah, I'm so hopeful and excited that we are moving away from just using BMI alone. Now, like you said, it's a helpful tool. It gives us some information and I think a good maybe starting point. But like you had mentioned, very important to dig deeper and look at other factors affecting their health and their weight overall. And you actually did an incredible module for the obesity medicine nutrition course that unpacks the different classifications in obesity and how we actually can diagnose this properly and stage obesity. So that is one of my favorite courses in the module. So if you guys want to learn more and really get into how it's diagnosed, how it's classified, you can join the obesity medicine nutrition course if you just go to examroomnutrition.com/course. And for my podcast family only, I'm offering a 15% discount. So you can use pod 15 at checkout for 15% off. Okay, Leslie, let's get into these cases because I'm really excited to unpack how you would handle each situation because each are unique and I feel as though each should be treated and handled differently. So we're going to start with a woman who is going through menopause. She's struggling with weight gain, and this is really, really, really common. She's noticed more fat around her midsection, and she's worried about cholesterol and long-term heart health. So let's start out kind of with biology and help us understand what role estrogen plays in body composition and metabolism that's unique to this patient.
What a great case. I mean, we see this day in and day out, and it's such a frustrating situation, but I think it really allows us to look at the entire picture and highlight just how much obesity is a disease because of all of these hormones that have to work together and how when one hormone is changed, it's like a house of cards that really falls apart, right? And also it highlights what we were just talking about, the importance of body composition and body distribution. So estrogen is active in multiple areas of the body. You know, the area of the brain that controls our energy balance, that controls our appetite, and then also with where our fat is stored, how our muscle uses energy and the quality of that muscle, as well as our metabolic rate. So when we start to see this drop in estrogen through perimenopause and menopause, and especially perimenopause with the just erratic changes of those hormones, I mean, appetite changing all over the place for individuals. And estrogen influences the activity of enzymes that determine where fat is stored on the body. So when we have higher or normal, however we define that, amounts of estrogen prior to this stage of life, we have our fat on our body is usually distributed more in what people call like a gynoid distribution, where in the lower parts of our body, like buttocks, hips, and legs. And then as that estrogen falls, that enzyme starts to prefer to create that energy storage through our middle sections and also depositing it in areas of our body like our muscle, our heart, so our other organs where we really don't want fat to be. And it starts that creates this cardiometabolic risk where the adipose tissue, fat tissue, is distributed in areas where it's not as healthy for us, increasing our risk, causing so much frustration. Because in this scenario, these women that are experiencing this, their weight may be the same on the scale, right? But where that body fat is distributed is completely different. And they may be doing all the things that they've done to live a healthy lifestyle, what we would define as like, wow, you're doing all the things, but they can't control the influence on these enzymes and they can't control where this body fat is being distributed.
For a woman who's coming in to see you, maybe in clinic, what questions would you ask her to maybe find out about the foods that she's eating to really understand her risk with, this stage of life that she's in?
When we look at this stage of life, it really highlights the biology, right? And what we can and can't control there. And then, but we have all these other pillars, our nutrition, our activity and movement, our behavior and sleep. So we always still have to assess those. So when I focus on nutrition at first with individuals, I really first try to focus on the why of eating and the how of eating before I get into the what. I just feel like so many of us have been conditioned with diet culture and our experience, and we've been told what to eat. And that's often what people think they need. And it's not that I don't talk about what foods they're eating, but at first, my questions are usually, what's your relationship with food like at this point in your life? What what do you feel that prompts you to eat? What gets you to start an eating episode? Is it time? Is it hunger? Is it keeping on a schedule? Is it because another cue from someone else? And how do you know when to end that eating episode? Are you enjoying food? Is it a chore for you? What pressures are you putting on yourself with food? I like to have that conversation first because often they give me everything I need to know from there about what their expectations, their food rules, how they should eat, how they can't eat. And then if we need to, we'll explore like the different macros or how they're building their plates and their snacks and what that looks like. And it usually gives me so much information to start to build where they're ready to change and where we can find value in the quality of their nutrition in supporting their metabolic goals.
I really like how you start with the why and how before even getting into the what, because I feel like you're right. A lot of us are just really conditioned to say, like, tell me about the foods you typically eat, which is a good and fine question. I really don't think there's anything wrong with that. But I really like how you kind of back it up and ask more about your emotions around eating, your relationship around eating and food and your body, because you're right. Patients will often just really unpack that for you and give you such good, useful information that sometimes you don't even need to find out, like, what are the typical foods you eat during the day, right? They've probably already given you that answer. So I think that's a really helpful pointer and really helpful questions that you guys should keep in your back pocket.
Yeah. I mean, one question that I think is one of the most powerful ones that I use often over and over is, what does that mean for you? What does that mean for you? Because there's the implicit and we have to make it explicit. Like we think that we are talking about the same thing, but we may not be. So when patients will tell me things like, well, I have 3 small meals and 2 snacks. And I'm like, well, what does a snack mean to you? What does a meal mean to you? What is the difference between a meal and a snack to you? And I balance my carbs and protein. Well, what is carbs and protein to you? Because sometimes we feel like we're on the same page and having this great successful dialogue, but we could be speaking two very different languages, right? And so I think that's so important in the nutrition conversation, but as we talk about behavior and lifestyle across the board.
This is probably one of the most important things that you and your patient get right. You've got to be speaking the same language. And I'm huge on definitions and making sure, like you just said, like what they mean is exactly what you understand. And I'll do the same thing with like parents who say that their child is, quote, picky,
Mm.
because it could mean 50 different things. And really, it is something different to each room, each patient in each different room. And so I love that question of like, what do you mean? Or tell me more about what you mean by that. So I agree with you so much on that. Okay, so for this patient, after we've had some conversation about, their lifestyle, their nutrition, what labs or tests would you prioritize for her?
So in this individual, we have our standard labs that we do, but particular in this individual, we want a metabolic panel to look at that glucose screen, kidney, liver labs, because we're worried about things like metabolic liver disease, of course, that can be a part of insulin resistance spectrum, especially in this time period of life. And usually we're checking for hemoglobin A1C and fasting insulin level to try to give us those earlier indications of insulin resistance, metabolic disease. Thyroid is important to screen to make sure we don't have another reversible condition that could be mimicking what we're experiencing. And, we have a lot of patients that will ask about, well, what about my female hormones? Can you check all of them? Unless someone is experiencing like premature ovarian failure, so that's usually like someone who's experiencing perimenopause, menopause symptoms before the age of 40, there isn't a lot of value to date in checking a lot of those labs because as someone's going through perimenopause, those labs can be very erratic depending on the time that you check them. And then once someone is through menopause, well, I mean, really our biggest indication of that is that they haven't had a menstrual cycle for at least a year. So although there are a lot of asks for those labs, it's usually not going to change our management or give us any specific options. We don't need those labs to start like hormone replacement therapy on an individual. So we would be looking at more of that metabolic evaluation.
I'm so glad you went there because social media is ripe with influencers, right? They usually don't have a medical degree, degree, but sometimes they do. And they're promoting like balancing your hormones
Mm.
or getting your hormones checked. So I'm really glad that you addressed that. Okay, so for this patient, and I know this is tricky because it will be very specific for every individual who comes into your room, but give us an example of how you would approach treatment in this stage of life for someone. So talk to me about lifestyle modifications, when and if you would consider medications, whether it be an anti-obesity medication or hormone replacement therapy, and maybe how you combine both of those treatment modalities.
So in an individual, we would do the assessment. We would see, do they have obesity? That's one of the first things. So if this individual has a body fat percentage above our understood threshold, if they have central adiposity to where if their waist circumference, and if this is a Caucasian female, for example, because there's different guidelines based on our ethnicities, if the waist circumference was higher than 35 inches, then we would definitely consider they would benefit from medication support, because they need their biology aligned in order for any lifestyle modification to have the impact that we need it to have long term. Now, that doesn't mean that we don't encourage and support and work on that lifestyle the whole time. It is always the foundation of any lifestyle related condition, just like diabetes and heart disease. I always encourage providers to think about it that way, that our lifestyle heavily influences high blood pressure, heart disease, diabetes, but we don't tell patients you need to live a perfect life for 6 months before I start treatment with the medicine. So we have to align the biology, help the patient be safe, and work on these conditions the whole time. So often in a patient that's going through menopause, I go through the pillars. We find one reasonable, sustainable nutrition thing to work on. People need clarity. They need focus. If you have too many food rules, you can end up in overwhelm, confusion, and then no change happens. So I try to find an easy win for them. How do they move their bodies? If they're not getting non-exercise activity, if that's where they're at, we focus on that first. So that's like our steps and how active we are throughout the day. If they're getting plenty of non-exercise activity, then we focus on how do we optimize that intentional exercise they're already doing in a way that they enjoy and it's not punishment. And then behavior, boundaries, helping women in this stage of life realize it is okay to set boundaries is one of my favorite conversations to have, I think. And gosh, sleep, 7 to 9 hours of sleep. And so the thing that makes this different is the perimenopause, menopause state heavily influences the quality of our sleep and our behaviors, et cetera. So if we would do all these things, but if a woman is experiencing a lot of these moderate to severe symptoms, then we would get them set up for potentially getting on hormone replacement therapy or treating those specific symptoms, because they will just amplify the complications of the weight gain and the body fat distribution as it is.
I really love how you incorporate all of the pillars to your treatment, because it's not an either or, it's both and. And I think that's where a lot of people go wrong, especially with the uptick in GLP-1 prescribing. And it's like, it's everywhere. You can get it from like telemedicine and like every business, every provider seems to be like a prescriber now. And I feel as though I'm concerned because I don't think that those patients are getting that comprehensive care. It's not just about here's your medication and nothing else matters. But my favorite thing that you do when you counsel patients is you make it simple for them. Because you're right, they're going to get overwhelmed with, great, now I have to focus on 15 different things and completely overhaul my entire life if I want to feel good. And then they're going to end up just having paralysis and not doing any of the things that you suggested. So I really love how you said to keep it simple and make it easy for them to achieve a quick win.
Because that's what we want for them in the end, right? We want them to win. We want them to feel empowered. We don't want them to be overwhelmed. And I don't want patients to fear that they don't have the tools to manage this long term. And what worries me, I love how you use the word prescriber, right? Because you're right. There are a lot of people that they're like, I treat obesity. And it's like, do you? Or are you maybe prescribing a medication, but it's all of those other pillars are so important because just like I tell my patients all the time, just like a blood pressure medicine, if you take a pill for blood pressure, it won't keep bringing your blood pressure down until it's zero. It has a level of effectiveness of what it can achieve. And then at that point, we either have to adjust our treatment, add treatment, but then adjusting our treatment, adding treatment is working on all of these other pillars. And plus, the metabolic adaptation will catch us, and patients aren't getting that education, so they feel like they've done something wrong, or they're having expectations that were never realistic for the treatment intervention to begin with. It's unlikely that someone can start one pill or one injection and lose 150 pounds. Most of the medicines, unless you're a hyper responder, aren't going to accomplish that. And we have patients that feel like they are failures because they're not receiving these results.
Yeah, it's so important to help our patients not feel that way because they're coming to us for that help and support, probably because they've already felt like they've failed, right? Diet and exercise have failed them already. And so we don't want to now give them a whole new treatment and then they just still feel like a failure. That's not the goal of treatment. And I love that that's your approach with your patients. And I wish more clinicians would, focus on all of those pillars, not just prescribing and sending them out the door. Okay, I want to move into our next case because this is completely different from a perimenopause, menopausal woman. And I want to highlight the differences here on how you think and how you would manage this patient. So, next, we've got a 50-year-old man with hypertension, sleep apnea, and he's class 2 obesity. He is actually coming in considering bariatric surgery, which is kind of like people forget that that's a treatment option. As clinicians are all about, GLP-1s and the new craze of the anti-obesity medications. We have other really effective treatment options. So he's coming in already with that in his mind, but he's a little bit hesitant. So how would you approach this first initial conversation with this patient?
Great conversation. This patient, the way we would look at this is first creating a safe space. I mean, that's so important. One of the best things we can do is welcoming them, find out what their goals are. My favorite question for a patient is like, what does success look like for you? When I first meet with a patient, what is a year from now you're successful? What is that health vision? I don't want to hear a number on the scale. How are you living life? What does that day look like? What are we making that number mean? And because we often make the assumption that the patient has the same goal that we have, right? Because as a medical provider, right away in this patient, I'm assessing, okay, they've got multiple obesity related conditions that can really be a threat to life. And how controlled are they or not? And so we would recommend the intensity of treatment that matches the severity of disease, just like any other chronic condition, right? So creating the safe space for the patient, hearing their story, hearing what their goals are, and keeping in mind for me with the conditions that they have, how much adipose tissue do I know that they need to lose in order to put some of these conditions in remission and support their long-term quality of life. And really walking them through that, explaining to them obesity as a disease. And then I would walk through our evidence of what is the likelihood that our current medications can accomplish that? And the reality of being on a successful intervention lifelong to maintain that success. We talk about cost and coverage. And I feel like it's informed consent. If this individual qualifies, it would be medically treated with metabolic and bariatric surgery, which they would. It is my obligation to inform them, educate them, that this is a very good option for them and it changes their biology. It is not forcing them to eat less because their stomach's smaller. Sure, there's a mechanical change there, but it changes the underlying biology. And I always hear people say, I don't want surgery, I want to get to the root cause. Well, I mean, surgery can change some of the root causes. So it's such an important conversation. And like you said earlier, it's an and conversation, not an or. Because often in a patient like this, I would tell them we should get you started on medicine and we need to get you in to see a metabolic and bariatric surgeon. And a lot of the pushback I get from patients is, that's cheating. That seems really severe. That's a last resort. And it breaks my heart that those are the things that I hear, because what it tells me is we're still not looking at this as a disease. So often with patients, I try to compare it to conditions like osteoarthritis or heart disease. And I'll explain, isn't cutting your joint out and putting a new one in kind of aggressive? I mean, isn't opening our chest up and doing open heart surgery kind of aggressive? But these are acceptable treatments that if our clinician tells us you have very severe arthritis, you have very severe heart disease to the point that this is the best treatment for you, then we move forward with it. We don't ask permission from our family members and friends. We do what we need to do for our health. And I hope one day, 5, 10 years from now, that will be the conversation rather than looking at it as a cosmetic treatment.
I know it will be different for each patient, but would you maybe start someone on an anti-obesity medication, see how much weight they lose, and then consider for bariatric surgery? Or kind of what's your thought process with the two of those?
I really give them the risks and benefits of the surgery treatment, the medication, and it's shared decision making. And if a patient's like, you know what, I never knew that the surgery actually fixed those things, I'm open to it. That's what I want. It's like, all right, let's go get surgery. Since that pathway to surgery is long for many patients, right? I mean, a lot of programs require 5 to 6 months, even though maybe someone has had a lot of education prior to. I will tell them, but we should still treat your obesity now and
Yeah.
and get them started on a medication. And so if they have so much success on a medication and while they're going through the process and they change their mind and they want to see if medication can sustain them long term, that's completely up to them. But we see a lot of patients that have surgery and need a medication. So if someone's disease is that severe, it really is probably going to be both to help them manage it lifelong.
Yeah, and I love how you stress the importance of shared decision making. And that goes back to what you said in the beginning when you first had this conversation with this gentleman was like, what are their goals? If in our mind we want them to lose weight, but maybe they just want to play with their grandchildren or be able to get up and down from the ground, easier when they're playing with their toddler, or whatever the case may be. Like you had said, that will direct and help you give better options to the patient to meet their goal. So I love that you approach it through shared decision making because that's really ultimately what it's all about. Okay, so I wanted to mention an episode that I did that's all about bariatric surgery because I really don't talk about it a lot. Now, I have been publishing, I'm already at like 125 episodes. So I'm going to bring you guys way back to episode 5, where I actually spoke with a bariatric dietitian. So episode 5 is called Bariatric Nutrition Basics, a clinician's guide to weight loss surgery. So if you want to learn more about bariatric nutrition, I'll link down to it in the show notes. But also in the obesity medicine nutrition course, I have an entire lesson on bariatric nutrition by a different bariatric dietitian. And it's really, really, really helpful to kind of guide those conversations and that decision making. So don't forget, you get 15% off this course by using code POD15 at checkout. Okay, let's get to our final case, Leslie. This is all about GLP-1s. And so we've got a young adult who recently started on a GLP-1 agonist. You could just, pick one as an example, Ozempic, because it's the most popular one, I guess. She's been losing weight, but she's struggling with some side effects, and she's worried about regaining weight if she stops the medication. So what are some counseling points and conversation tips that are most important at this stage for this patient?
Where I start always with counseling is I always have to make it very clear to the patient as that reminder of it's not your fault. As the concern of the weight recurrence, because so many of us put it on us of like, okay, and I hear it a lot too. So if I do all the things, if I'm really good and I follow all the rules, and if I work out really hard and I really diet and I come off the medicine, like I can maintain it, right? There's a small percentage of people that it seems like they've been able to, right? But we haven't been able to study them. We don't know why. We don't know the details. But for most of us, coming off the medicines, I always explain to people that the way the body regulates all of this is as we lose weight, adipose tissue, hopefully, brain is aware it crosses a threshold. Brain is not happy about that weight loss. It can tell by the drop in hormones, and it sends a cascade of signals down through the body to fight back against that weight loss. Hungrier than you ever were before, never as full, drop in metabolic rate. Your emotional experience of hunger is out of control. The reward you get from food is higher. I mean, these are primitive functions. So you are not going to be able to just like willpower through that the rest of your life, right? And so when you're on something like a GLP-1, that medicine is holding that biological response at bay, and it hasn't been cured. It's not gone, right? It's just managed. And then you take that medicine off, wow, just this powerful, it's like a dam that's been released, right? This just powerful overflow, and patients experience that. And so if people are aware of that, they're scared. So people need to know the reality of coming off of that. And, I'll counsel people through not all GLP-1s are experienced the same in different people. There's also combined incretin hormone treatment as well too. So we may need to try different ones that may not give the same side effect experience for that individual. And yeah, there are strategies that can help in terms of really utilizing the hormonal regulation of appetite with really maxing out that high quality protein and the mechanical stretch of the stomach. Can we fill our stomach with lots of low calorie density energy to just fill it? Can we use a lot of fiber and things like that to try to control that hunger experience as much as possible, and see if that helps manage it? So we can use all of the lifestyle things we have possible to create strategies to manage that hormone return if we have to. But for so many, it's not as powerful as the medication.
There was a post recently, I think by another obesity medicine physician, and he was sharing how a lot of his patients are really scared when the clinician says you have to be on this medication forever, because forever feels final, right? It's like I'm never going to get better from this condition. And so how do you navigate that explanation of like, this is long-term treatment with a patient, and what terminology do you use? Do you say like, yes, you need to be on this medication forever, or how do you handle that conversation?
Every now and then I may end up saying forever if someone really is like how long? Like really how long? Like 10 years, 20 years? And often I'll say, hey, we don't know to date. And it all depends on your individual body and whether or not it accepts this lower weight threshold. The evidence we see now is most people, our body keeps fighting back. And I try to compare it to other chronic diseases. And I also will offer the opportunity that when they get to a point that our evidence doesn't support this yet, but if a patient really wants to come off, I'll tell them at the front, this is what we'll do. I recommend being at whatever goal is for you for at least 1 year and be at a point where we're getting amazing sleep. Our resistance training and our muscle quality is very good. Our nutrition's really good. We're really setting our routines. We're in good emotional health. And we can assist you with medically supervised trial of weaning off, and we'll see how your individual body responds. But if we experience that recurrence, then we know for us we need continued treatment. Because I think saying everyone has to be on it forever is probably not accurate. So we just don't know yet. So I usually tell patients, from what we know now, I suspect you're going to have to be on this long term. How long? As long as we care about how your weight affects your life, how the adipose tissue affects your life. There's so many things that go into the body's biology to balance this. We just don't know yet. And it has to be highly individual, and it needs to be practiced by people that understand the entire scope rather than being like, nope, med for you, stay on the med forever, end of story.
I love that approach. And I hope you guys are listening and hearing this loud and clear. It has to be individualized. And while, we're still in the midst of studies and maybe guidelines will change in the future, but until we know more, you have to take it and address it with that one patient sitting in front of you. And I think this leads me nicely to my last question that I just want to kind of bring this full circle and round it out. Even though you've given us some great questions and ways we can approach this, what are other approaches or questions that you would love for clinicians to ask that would open the door for a more productive, compassionate conversation about that patient's obesity care?
I think at the end of the day, just really leaning into understanding what has that person's lived experience been like with their weight, with their obesity, because obesity affects us all differently. And that's so important. And really trying to make sure you understand where their journey's been, because that person in front of you, they may be significantly weight reduced and they are thriving in their life, and that person in front of you may appear to be in a small body, but it's the highest weight they've been in their entire life. So please, I would just encourage with an approach, spend the time to understand their lived experience that will help you guide the treatment plan, and just stay curious and also very intentional with your language. I overhear so many well intentioned providers say things like, well, I think you're overeating. It's like, oh, overeat. Like, I try to, and this takes time, right? But I work through things of saying, I think the food that we're taking in, the energy, may be more than what the balance of our body needs. I'm saying the same thing in a
Hmm.
very different way. And just pay attention to your language, help the patient understand what is in their control and what's not in their control, and highlight that, and really lean into being curious and understanding what their experience is, and honor that.
And you're so right. It's so easy to be so clinical and sterile, honestly, like with our advice giving and our education, because you can just feel like you're in this like hamster wheel of like going in and out of patient encounters. And we all face it. We're all burned out. We're all have are overbooked, but really I would highly encourage you all to really take what Dr. Golden had said and get to know your patient. Listen to their story because everybody comes in with a story. Well, this has been such a fun conversation. I love working through those different cases and just picking your brain how you would treat each of them differently, but still with compassion and with shared decision making. So thank you so much for the gift of your time today and in that course that we have created together. So I just appreciate you being one of my colleagues and being such an advocate for appropriate compassionate obesity care. If people want to connect with you or hang out with you online, where should we direct them to?
Absolutely. Thanks, Colleen. It's been a pleasure to be here. And if you'd love to learn more about me and what we're doing at Weight and Gold Wellness and how we approach obesity care, weightingoldwellness.com, our website. And we are on Facebook, Instagram, and TikTok.
We'll link down to all of those handles below for you guys to get connected with Dr. Golden. And Dr. Golden, thank you again for the gift of your time. I appreciate you very much.
Thank you.